All right, so welcome to the inaugural episode of the ARME Radio podcast, where our goal is to offer accessible education to health and fitness professionals and also bridge the gap between research and the practical setting. So I'm Dave Emond, we've got Elliott Perkins, Mike Edgar, and last but not least, Ben Csiernik, who's going to take it away with the topic of today's episode.
So today's episode is going to talk a little bit about the different ways that we look at an assessment and an evaluation of a new patient or a new client, and what our initial interaction has and how important that needs to be. And how we're going to look at that right away is we're going to start from a relatively new article by Adrian Lowe from this year, titled Evaluation as Treatment for Low Back Pain. It's published in the Journal of Manual and Manipulative Therapy. So what this study we'll talk about what it's looked at quickly, is it had 34 patients with low back pain that didn't go below their legs. So that's who came in. And basically patients came in, filled out a form identifying a few different things. They did testing on pain, on their fear avoidance, how they viewed their pain, basically their flexibility to touch the toes, and some pain pressure thresholds at a few different points. And all the intervention was the patients did all their testing before their history and physical was taken by a different assessor, and then they measured those same criteria after the history and physical was taken by the practicing physiotherapist. And what we found were a bunch of significant changes in things like pain and pain catastrophization and lumbar flexion and pain pressure threshold, but the only one that met their minimum criteria for an important clinical difference was pain pressure threshold. And so what that means is authors acknowledged that there was a statistically valid and significant change in a bunch of the criteria, but the only thing that really meant something to the patient was the change in that pain pressure threshold. So that's the brief summary, is that maybe just the experience of a history and a physical is good enough to provide some changes over a couple big categories. So what do you guys think about this article? And we'll throw it to Dave first.
Sure. Really important article in terms of maybe looking at all the other factors that contribute to someone getting better and their outcomes, that isn't revolving around just putting your hands on them and getting like some type of therapy, like manual therapy, to be like that quick fix. And I think we can all agree, because we've been talking about this for a while, that one of the best ways that you can kind of see how an outcome is going to unfold from a clinician standpoint is that early sort of connection that you can make with a patient. So through positive language, being able to understand their values, these are all things that are extremely important, and that will kind of dictate the course of treatment from that assessment's point of view. So I'll let you guys kind of chime in with that as well.
Elliott, thoughts? Oh, Mike, we're going to go to Mike here quick.
Yeah, I just want to chime in here. I know a few of you guys are doing telehealth right now, and I'm just curious what your perspectives are on that, given the whole idea that we can't use hands-on therapy, and as chiropractors, that's kind of where our identity has been. So I personally think it's a good thing. It gives a new avenue to run down, as you just said, and the ability to kind of break those stereotypes and those norms. But what are your guys' perspectives?
Elliott?
Well, the current pandemic that's going on has made a lot of professionals resort to telehealth and non-in-person consultation with patients. And the fact that patients are still having results and still getting better with these sessions shows the importance of not just the manual therapy, the hands-on aspect, but the interaction, the therapeutic alliance between the practitioner and the patient. That it's about having being able to listen, being able to educate the patient as for what it is that's actually going on and ways to be able to self-manage. This all comes out after the physical and the history, but even just the being heard and having the source of, or the diagnosis, whether it's a specific diagnosis or not, just having the idea that the patient is getting their problem sorted out can be extremely beneficial psychologically as well as physically.
Yeah, totally. Dave, you want to add in there?
Yeah, so I think a big barrier that we see from that initial assessment point of view is some people come into the clinic where the assessment is sort of like a part of it that they just have to endure before getting fixed, right? And I almost see like a pretty good opportunity here with telehealth, because you can almost take away that expectation. And like, we know that there is that importance of being able to have a really good conversation, right? Like, we're taught in school, and I feel like probably a lot of other institutions kind of teach this way too, that the main goal of a history is to figure out what's wrong with somebody and come up with like a structural diagnosis. And obviously we want to rule out red flags and stuff, but I think maybe instead of trying to figure out what's wrong with a person in the history, we want to figure out the person, right? So being able to have a really good long conversation without that expectation that we're trying to rush things and figure things out and ultimately do something to get them better is a fantastic opportunity to, again, kind of set the foundation for a really good future interactions. So maybe, and I want to get your guys' thought on this, is maybe there's the potential for implementing telehealth as like almost like a quick clinical assessment before you ever see somebody in a clinical setting, so that you can have that really good conversation, get to know them better. And then if you ever see that there's red flags or any other more details that you have to get into with a physical exam and stuff later on, then you can do that at a later appointment. But I think it's a pretty good opportunity to really understand patients through that history without being rushed.
Yeah, absolutely. Mike, do you have a thought on that?
Yeah, I was going to note one thing, kind of what you said about how we can have a quick little consult with the patient beforehand, just to kind of gain that relationship with them. I almost want to go back and say, does it even need to be quick? Like, I understand money and finances are important, but there's this big perspective of, yeah, the better you get at your physical, the quicker you get. But if we look at it from the other perspective, where the treatment isn't now the goal, it's not the finish line, and we can look at it as the history, and the physical can be part of that treatment now, based on what the study is showing. Do we need to make these histories and physicals so quickly? I think one of the major things from this study was looking at just the variety of times for a history and a physical. It ranged anywhere from like 4 minutes to anywhere to 40 minutes. So it shows you the variety of that timeline. And I think instead of trying to look at it from, yeah, I can finish this history and physical in X amount of time, maybe it should be looking at, yeah, I can get this patient to trust me, or to get this patient to feel a certain way in this amount of time, instead of just trying to beat your old times to get to that treatment.
Yeah, I absolutely agree with that. I think we can do a bunch of different things that way. We don't have to rush things unless, again, like maybe a person prefers things to go faster, and that's potentially something that you have to kind of get to know and judge yourself with that patient in front of you. Elliott, thoughts on that?
Yeah, a few things that are interesting in the paper that they did look at was they looked at the amount of time in each assessment. Then they saw there was that was that range, and then also they asked the practitioner what their perceived connection was between the therapist and the patient. But so this is on a doctor's perspective, or a practitioner's perspective, rather, compared to rather than the patient's view. And they were also able to determine, how well did I connect with this patient? Was I able to have some sort of relationship forming, start to build that therapeutic alliance? The average was 7.15, or the mean score was 7.15. So throughout this, all these practitioners had a pretty good connection with the patient, and that's pretty really points towards that as well.
Yeah, I agree. Dave?
Yeah, I think we're all pretty much on the same page, where that first discussion and getting to know them is probably the most important aspect, right? Because again, looking at the paper, we even saw things where if the physical exam was taking too long, then there can even be some negative perceptions from the patient, thinking like, this person's taking a long time. Is there something really wrong with me? And even from like that physical examination, like, it is good to sometimes get your hands on someone, because that's another way to build trust. You don't have to, but again, it's kind of a bad opportunity for a clinician just to kind of confirm their biases. So if you're spending a lot of time poking on a muscle and being like, yeah, it feels more tight here, the longer you poke on it, the more you're going to say, well, yeah, that must be the problem then, right? So maybe keeping the physical exam a little simpler, and instead of using it, unless we really need to rule out like red flags or see if there's something truly like pathoanatomical going on, it's a great opportunity just to get them to move and understand what movements feel good, what movements feel bad, and then just having them learn different strategies, right? That might be a little bit more beneficial for them to understand what's going on.
Yeah, Mike?
I'm just going to throw one thing too that I just want to mention on that. You mentioned about red flags too. I notice a lot of people, especially myself, you kind of feel limited some of the time with when you have a patient that maybe has some of the flags that make it so they're contraindicated to manual therapy. Like for example, I had a patient that there was a possibility he had metastasis to the spine, and therefore we couldn't do cervical adjustments, which was what he expected in that treatment. I know at the time when I first started doing this, I felt useless, like I couldn't do anything for him. That being said, I think this offers a good opportunity to realize you don't always need to put your hands on someone to help them. And no matter the condition, you can do something just by listening to them. And that just kind of gives credence to the whole idea that although we don't have a range of things in our scope of practice, we can still help people with a range of conditions just by listening to them.
Yeah, totally. I mean, like, I think just even if you look at the statistics from this, it's like a small sample size from this paper, but in both lower back pain and patients with leg pain, like 25% of both on average groups actually improved over that minimum threshold from this group. And like Adrian Lowe's authors couldn't determine if that was whether from the history or for the physical or both, but I think it's really interesting that it, you know what I mean? This was a very hands-off process and people had met a threshold for pain improvement just from that. So I know I kind of jumped in over you there, Elliott. Did you have any other thoughts on that or from something earlier?
Yeah, just bringing in the idea that we've talked about many times, the idea of placebo versus nocebo, and how our expectation or the patient's expectation in an interaction can very much influence the outcome. And the fact that a patient would be coming into an examination and expecting treatment to help before they even get treatment, they reevaluate and find that they're already feeling better, that their pain is already improved before they've even received the treatment that they are expecting. Now, the inverse of that is the risk of a physical exam. This is just personal experience in my own process, but it's very important what language we use when we are examining a patient, we're talking to a patient. There's some very scary words that we can throw around that, this tissue is damaged, this is out of place, you're misaligned, you're fragile, all this really great stuff that just gets people to live in a box for the rest of their life. But avoiding, you can actually use that physical exam, not just the history, but as an option to point them in that more optimistic direction. Using the physical exam, like, does this orthopedic test hurt? No. Good. Like just say, okay, good. This doesn't hurt. This range of motion, your range of motion is actually really good. A little bit of pain at the end range, but not too much. Your range of motion is pretty good. Having and reinforcing all the good things that we see in this examination. Really reinforcing that, okay, this isn't because, especially with back pain, most back pain isn't caused by any form of pathology. Nothing structurally is wrong. It's a sensitivity of tissues. So really having the patient recognize that just by getting them to move in certain ways, and you can reinforce that with the language. This is great. You're able to do that. Even doing some of these movements are not aggravating, but even relieving and things like that. So this is also just sets up that opportunity. I know that Dave really is really dying to chime in here.
Well, no, those are like fantastic points, right? It's super, super important to stay positive, and like you hit the nail on the head there. Something that we had talked about previously, and Lorimer Mosley touched on this in his webinar with Craig Levinson. It's almost to an extent where it's really important for us to not say anything negative, or like we really have to watch that we're not noceboing something or someone, because that might be more important than the actual positivity, right? The positivity is super important for us to get points across and then like build, like you said, to make someone more resilient because they are. But even if like we want to extrapolate, so there was a study by Bielowski and Bishop where they were actually looking at positive versus negative expectations on SMT. so spinal manipulative therapy for low back pain, and effects of, was there less pain or more pain? And what they ended up finding was, in the group where there was a lot of positive expectations, so they told them, like, people who get low back manipulation feel incredible, everything's like way better afterwards. Those people responded well, but they didn't respond much better than one of the groups where they just didn't say anything. So like both those groups got better. And then when they looked at the third group where they were telling them, look, you're probably going to be in a lot more pain, this is going to hurt before we do this, they showed like way larger negative results from that, right? So that sort of nocebo effect, or that negativity, can have a more profound effect compared to the positive stuff. So like you can have this fantastic interaction with somebody and be super positive, and if you slip up on a couple of things and everything's going great, but then you're just your core is unstable, that can really set you back. So I think it's really important for us to watch out on those things especially.
Yeah, totally. Mike, do you want to add in?
Yeah, I was going to go off on a little bit of a side note here. Just when we had that discussion earlier, Ben, I just wanted to mention how I do really appreciate the study, and you mentioned the same thing, for the fact that they did mention the difference between the statistical analysis for the significance versus that clinical significance. I think that becomes really important because a lot of people get hung up on that idea that, oh, there was a significant result, not realizing that sometimes it doesn't translate to the clinic so well. And Ben, what did you mention about what they found for that?
Yeah, so I'll touch briefly. One of the strengths that I think we all viewed like around this Adrian Lowe study is that they mentioned the minimal clinical important difference, which is a metric that's being used a lot more in pain-related research, and most often for pain or significant difference, that's around 2 out of 10 or on an 11-point VAS scale. So anything for pain and minimal clinically important difference is anything more than about 20%. And that kind of varies between 15 and 20% depending on who you ask. But what this paper showed is that there was statistical significance on almost every measure they found. But what the authors chose to acknowledge was that they didn't really care what the statistics said. If it didn't make that minimal clinically important difference, so something that actually was considered meaningful to the patient, and we use those metrics kind of arbitrarily of what's meaningful, but they decided that they wanted to use like more hard objective facts, and it's something that I think we all really respect about this paper, that they're willing to do that, because it's easy to say, as Mike was saying, that, oh well, we found a statistic difference, that pain went way down statistically, it's significant, now we can conclude that this is absolutely something we all need to do. And it's not true. Like, pain decreased about the same amount, so about 15% in this paper. That's typically kind of what we see with most therapies. We see that between 15 and 40%. 15 might be a little on the low end, but that's not something completely unsurprising when we have a therapeutic intervention or a therapeutic relationship with the patient, right? That's kind of what the data consistently shows. So what this paper goes to tell me is that we are able to see one clinically important difference, maybe in a metric that I don't think many people would necessarily say is the best metric, in pain pressure threshold, but the significant but not clinically significant differences can kind of be interpreted however you want. So I don't know who wants to jump in on that, but I think that's a great point. Like, I think we need to acknowledge when there's statistical significance, we can say that's interesting, but that doesn't mean we change everything we're doing. Even if it's a paper that we believe is leading us to a good point, we have to acknowledge the limitations there. So Mike.
Yeah, since I guess no one else is chiming in too much right here, I think the big thing again is, just don't look at things black and white, as you said. It's a bit more complex than that, and to use your clinical experience to translate this knowledge over, I think it's important to know that, like, a lot of traditional chiropractors, I use the word traditional in quotations, tend to think a lot of the newer chiropractors are boxing ourselves in by looking only at musculoskeletal conditions or only looking at X, Y, and Z. But I think this paper kind of shows, and what a lot of us are trying to think of nowadays, is that we don't just need to box ourselves into manual therapy. We're doctors at the end of the day. That word literally meant teacher. And I think this really highlights the fact that we can be teachers, educators, and communicators with our patients.
Yeah, absolutely. My favorite point before we get to you there, Dave, is my favorite takeaway from this entire paper was that the history yielded the biggest changes in the evaluation process. So they took measurements before anything, and then between history and physical, and then after physical. And the most significant changes occurred in that first, 5 to 15 minutes that practitioner spent with the patient. I think that's, again, like really an important thing to point out. Dave?
Yeah. So just to like expand on that importance of that, maybe we can all kind of chime in. Like, what have you guys used as strategies to better connect with your patients in the clinical setting, or even Ben in sort of like the fitness setting, right? Strength setting, to kind of just make that better connection and take advantage of a potential benefit of outcomes through just talking to them at first.
Well, I like to always wear a gown as well as the patient so we can connect. Sorry, I had to put that in there.
Yeah, fair enough. Mike?
Yeah, I don't get that intimate with my patients, and actually I don't really practice right now, like coach. So, I mean, it's hard to get really intimate with your online clients. That being said, though, when I did treat back in my intern year and right now in my residency, I'd say the biggest kind of, and it happened serendipitously, was volunteering at a local church and retirement home. I'd never done anything like that before, and it was really cool, just from a different perspective. But I actually had some of the patients that would see me in the clinic also see me in that setting. And I think that just gave them a new perspective, like, oh, he's not just my chiropractor. Oh, he's here to help me not just with my pain, but also with my fitness. And like, I think kind of seeing these people in different relationships can also help build that trust, because end of the day, a lot of it just comes down to exposure too, right? You see that person enough times, and more than likely you're going to like them. Or if it's Elliott, you might not like them as much. But either way.
Yeah, so I think that's all really great points. And so we've talked about how this paper outlines, like, yeah, that history and that physical, that initial connection value so much. And then we kind of touched a little bit on how telehealth is forcing us to really primarily focus on a different type of communication. And I know that both Dave and Elliott, you guys have both had a bunch of telehealth stuff going on now. So do you guys have a case that you thought was like a really great experience for maybe a patient before that had seen you in only like a more hands-on setting, or even like a new patient that you want to kind of speak about, and how you tried to kind of implement like this new form of communication with them?
Yeah. Now that we are able to have new patient assessments, that's kind of changed things a little bit, or at least reassessments. And like, without giving too many details of specific cases, it's been a really positive experience to see the difference that you can make just by having that chat with somebody. Obviously, like, we can go in through running people through exercises and stuff, and they like that interaction too, right? But again, without that expectation that you have to really do anything, and you can just sit down and have that conversation with them, it's forcing me to ask more meaningful questions and to sort of look into some of those other realms that might be contributing to someone's pain, whether it's like, a death in the family, which I've seen, where someone went from being much better to like they were 100% after the death. Things kind of regressed. So it's about being able to work through some of these aspects, and I really find that with some of these interactions too, it's been a great opportunity to get to know people better and to make those relationships, because that side of things of, okay, let's get you on the table, isn't really on the agenda, right? So just being able to talk more and develop communication skills has been huge with this.
Yeah, for sure. Mike?
I actually had a question for mainly Dave and Elliott. It might be a bit of a loaded question, but I know when I first met both of you, I was in the same boat to a degree, but I obviously didn't have the same formal knowledge about it. But you guys are both very biomechanical based, very rigid in that philosophy. Obviously, coming from your background education, I'll let you obviously elaborate on that. But I've noticed a strong transition now, especially over the last X months, moving towards this kind of pain and communication alliance, looking at more of the soft aspects of these things. I know, Ben, this is more of your alley, and it always has been, but I also noticed that you guys have transitioned, and I want to understand how you transitioned, why you've transitioned, and what you think your former self would have done in this situation with telehealth had you not known this stuff. So if you were so rigid with those biomechanical thoughts, do you think you would have been as useful over telehealth as you are now?
Yeah, it's a great question. Elliott, do you want to start us off there?
Yeah, well, before I even went through chiropractic college, I was at the University of Waterloo, and my degree was almost entirely biomechanics. It was looking at physics, looking at math, looking at tissue loading. It was looking at the body rather than the whole person, and that was my perspective going into it. But thankfully, I am not in a box, and there's a lot of really good research out there that I've been doing my best to keep up with. And when we if you keep that perspective that I had, that biomechanical focus, you can't, it's only part of it. We have a biopsychosocial model of healthcare. The biomedical solely is very limited. And as I was exposed to new research and new ideas, I don't get stuck in my biases, and I'm able to change my mind with when presented with data. So it's pretty much a no-brainer. As an evidence-based practitioner, I follow the evidence and let that guide my decision making.
Yeah, absolutely. Dave, you want to add on?
Yeah, I think like I come from the exact same background as Elliott, right? That was kind of our upbringing, and just being a former strength and conditioning coach, you were helping people with that, right? I think the biggest thing that helped me transition was being able to, one, look up things that I didn't know, but before even doing that is having conversations with people from these other perspectives. So me, a big part of that was talking to you, Ben, and you questioning some of the things that I was saying. And then I went and looked it up and I said, okay, wait a minute, there's a lot more to this. And when looking back, because we all, when you're a clinician, you can fall into that whole post hoc thing where I did this is my philosophy, these people are getting better, so it must be right. But when you actually take that big step back, sure, I was helping people get better through that biomechanical approach. But when I really take a step back and look back at the people that were getting better and I was having a lot of success with, it all came down to those were the people that we jived really well with. We had these fantastic interactions. We got along well, similar interests. The message just wasn't a chore to get across, right? Which can happen in some cases, and that's on us. But really looking back at the people that you're having a harder time with, that connection wasn't quite there versus the people who are getting better. So that gave me that opportunity to think that, maybe it doesn't really just come down to the biomechanics and doing the right exercises, right? It really comes down to that whole interaction.
Yeah, I think those are both really important points. And it's tricky because it's a really, really friendly system to think this person's shoulder pain is because their shoulder doesn't move this way in space. Like, that's a really tangible goal that you can see as a clinician and a patient can kind of relate to. But then we kind of learn that the patient can get out of pain without that goal ever being achieved. But that doesn't mean the process that you attempted to go through to maybe change that motion wasn't what helped them. And I think that is kind of why it's muddy and confusing. But I think you guys both made some good points there. So Mike, you want to add on?
Yeah, I'll just add on to that. Well, basically what you just said, the idea of, well, you might not have X amount of range of motion, but that also might not be causing pain. This kind of just goes back to what they constantly are trying to push into us, which is the idea that you aren't your imaging. Like, you aren't the structures that you're made of. And this is where this comes into the idea that sometimes I feel like these biomechanical philosophies and the words used for it can just lead to these fragility complexes within the patient, where they just feel like, oh no, I can't move this amount of motion, or I can't do this because I'm afraid that I'm going to break something, or that vertebrae is going to shoot out of my spine and bounce across the room. And I think going this new direction is probably better off for everyone. And I think this new push towards telehealth will at least embrace that a bit more, or at least drag the people that don't want to go there kicking and screaming.
Yeah, absolutely. And Elliott, we'll get to you here, and then we'll kind of start wrapping things up.
Yeah, I was just just punched my camera here. just the I don't want to downplay the we're not saying that the mechanics don't matter, or
Thank
that
you. Yes, good point.
it doesn't matter. We have the people look at this and they look at the pain science research and it's like, oh, this pain science research is saying that, oh, the biomechanics don't matter. No, they absolutely do matter. It's the biopsychosocial. We have the biological. We have your back, which hurts. And then we have the psychological aspect of that, the way your brain is interpreting nociception versus pain, creating this pain environment. Then we have the social aspect. How is this affecting your life? It's the entire thing. So yeah, if your shoulder hurts when you move it in certain positions, well, the mechanics of you moving your shoulder in those positions obviously plays a role, because if you don't do that thing, it doesn't hurt. But it's just more complicated than that. And there's more to it than that.
Yeah, absolutely. I think the best thing I heard to describe kind of this like wild pendulum swing argument that we see all the time is, well, there's two things. One said, well, biomechanics exists in every single thing you do. Every time you take a step, it's biomechanics. So no one's saying biomechanics doesn't matter. We're just saying that sometimes it matters a lot and sometimes it matters a little less. And then I think the second biggest thing, and this is my favorite quote, and it's from Ben Cormack, so I'm going to steal it from him, is he said he's going to start getting worried the pendulum swung too far when patients come in asking for them to adjust their attitude. And I thought that was a pretty funny way of looking at that. So we'll swing it over to Dave and then Mike, and then we'll kind of wrap it up.
Yeah. When you're looking, because some people look at the whole biopsychosocial thing as like three components. It's really just one giant thing, right? It's the integration of all three of those. And the one comment that I saw just the other day was somebody had said, well, like, I've looked at Mosley's work and he's just saying like pain's pretty much all in your head, but isn't back pain, like, doesn't it have to do with the facet joints and the muscles and stuff? And like yeah, it can, like, there's something going on there. Those tissues can feel pain. Nociception is a real thing, right? We're not saying that there's not some type of signal being sent from those tissues up to the brain. It's there, and you want to find a way to manage that. And we usually find good ways to manage that through movement too, right? So again, you shouldn't be dispelling, like, it's a giant spectrum, right? So we shouldn't be saying biomechanics is wrong, psychology is wrong. It's all integrated into this one system.
Yeah, absolutely. So I think we covered a lot of stuff there, and I'm just going to kind of quickly summarize it. I think our biggest takeaways is that if we start with that Adrian Lowe papers, is you need to know that as soon as you shake hands with that patient or you're introduced to that patient, it's started, right? That interaction's began, and your opportunity to make an impact on a person starts the second you meet them and the second you talk with them. And I think we can all agree on that and how important that is. Does anyone else have some final comments here for us today?
Look at that. Good solid first discussion, guys, I think.
Yeah.
Yeah, the first time I've ever had nothing else to say.
Wow. Tune in next time for when Elliott makes a dumb comment at the end.
Yeah, I think some of those will start popping up in the future, right? So, no, I think all in all, that was a pretty good discussion, and I think it's worth whether people want to listen into this or not. I think it's important to have these discussions so that we can keep moving forward, right, and keep learning, because some of the stuff that we talked about today might not really be as valuable 10 years down the line, right? So you guys said it. It's about adapting with the evidence and adapting with what we're seeing in the clinic. So all in all, pretty good first episode, and we'll see what we have in store in future episodes.